Thank you, Matthew. You know, for 24 years, these have been my mentors. I've been sitting at the feet of these guys. And you know, it's just awesome, their intellectual vision and technical expertise. So all I could say, you know, listening to these two war horses speak is just, you know, wow. It's just, they're amazing people. But my job is to bring us back to earth a little bit and share with you what we've been able to glean from all the data that Rick Geyer alluded to. And you may see some overlap in our slides, and you know, I'll just, if I can't give you a different spin on it, we won't spend any time on it, but you know, my job is to go into a little bit more depth as to what we've been able to find. So, you know, as Rick had shown you, the number of devices we've put in has been impressive over the years. We were very early adapters. So, you know, we're speaking from clinical experience because we have to take care of these patients. So, you know, we're not just pulling numbers out of the air. And in TBI, we have almost 30 surgeons, but the main work has been done by Drs. Geyer, Dr. Blumenthal, and myself, because again, we took the chances early on when we started the FDA studies that this would be a good technology. We were willing to do it because it was being done in a scientific way for once. And this is one of the things that, you know, as we watered the plants, we've finally been able to see the flowers come up, and that's what I'd like to share with you today. So as Dr. Geyer mentioned, there are 9 cervical implants that have completed FDA trials. All of those were level 1 studies. They were all prospective randomized studies controlling the patients to ACDF, except that there were 2 studies where historic controls were used. That was the M6 and the Simplify study. But the others used progressive randomization, and there were 3 devices currently approved in the US for 2-level. It's the Mobi-C, the Prestige LP, and the Simplify, but all of them have single-level approvals as well. So I like to look at them in aliquots of 3. The what I call the legacy discs were the original ones. That was the Prestige Stainless, which is the old Frenchay disc, the old Bristol disc. Then the ProDisc C and the Bryant, and those are the years that they were FDA approved. And of those original 3, only ProDisc is still commercially available for sale in the US. The other 2 have been withdrawn from the market globally, actually. The next aliquot were the PCM, the Secure C, and then the Mobi-C, which, you know, hit a home run at the time because it ran both a 1-level and 2-level study independently and was able to get their approvals for both of those at the same time. Since then, the PCM is no longer in the market. My understanding is the Secure C has a very limited use, and with Globus acquiring NuVasive and Simplify disc, that disc may not stay on the market very long. And then the more recent discs were the Prestige LP, which Medtronic also ran a single and 2-level study and got single and 2-level FDA approvals in different years. The M6 and the Simplify disc, which similarly has 2-level study arms and 2-level approval. The study that Centinel did with the ProDisc C variants, with the Vivo and the SK, and allowed the surgeons actually in a 2-level patient to match the individual disc to the pathology at different levels, so you can get different implants in the same patient. That data has been all collected and is sitting with the FDA, and hopefully approval will happen sometime this year. So there could be a 4th disc with a 2-level cervical approval. So just to reiterate that. The result of all of these FDA studies for the discs that have passed through and the discs that ran studies and didn't get FDA approval or withdrew, the result of that was publication of a huge amount of data, of level 1 data, something we never had before. And as people completed studies or participated in studies, they published papers leading to that big curve that Rick Geyer showed, so that we are able to mine this mountain of data now and slice into it to answer some questions that we've never really had the ability to answer intelligently. And this is just showing the cervical arthroplasty publications, the explosion of initially lumbar, and then that sagged a little bit as lumbar approvals were harder to get in the United States, but at the same time, cervical studies had started. Cervical studies were gaining a lot of momentum, had a lot broader base because there were so many more companies and implants doing studies, so that area of productivity in publication has continued to rise, and you can see it's a logarithmic increase in publications in arthroplasty and spine when you do a PubMed search. So we were able to get this, and it gives us the best cumulative evidence that we've ever had for any implant in the body. And if you think about it, things that are implanted all the time, every day, all over the world, things like hips and knees, plates and screws, rods and hooks, even non-orthopedic things like intraocular lenses or cardiac devices never had this level of scrutiny. John Charnley did not have to do a prospective randomized study of hip replacements versus fusions, and yet, this was the implant of the century by Lancet when they started to publish long-term data. So the head scratcher is that despite the publication of this unbelievable amount of data, that there are still skeptical payers, there are skeptical insurance companies and governments, but there are also skeptical surgeons. We run into this at large meetings, and it's just hard to understand. But the big push, at least in the US, and I think around the world, is coming from patients. Patients are becoming increasingly more educated. They are asking surgeons, why are you not offering me an artificial disc? And I think that's where the big push is going to come from. Since we've been unable to do it with science, it's really going to come from patient demand. And interestingly, in the US, lumbar has opened up because of patients' demand through attorneys and class action lawsuits, and that has opened up insurance companies' policies, not us with all our paperwork and science, but it's been patient demand. So as Rick had mentioned, the results are consistent. They're not scattered. It's not some are great, some are good, some are bad. They're all good. They're all good to very good, and the data continues to support that. He showed this slide, but the reason to look at this slide a second time is we presented this and asked, and as Donna Unmes told us, this is the only question that's exactly the same in every single study. Nothing else is the same. Even a VAS line in some FDA studies, it says, what's the worst pain you're having today in your arm? Another study says, what's the worst pain you've ever had in your arm? Another one says, what's the worst pain you've had in the last month? So you can't compare that. They're apples and oranges. NDI is apples, 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 apples in every single study. So here are 11 or 12 studies with their controls, all showing the exact same hockey stick. So this is the best evidence we've ever had showing the improvement patients get after surgical intervention for cervical radiculopathy. And you can see the artificial disc patients do better than the fusion patients, but the fusion patients still do well, and certainly better than failed 6 weeks rather, or 3 months or 6 months of conservative care, which is where they started out from. So immediately after surgery, they get this drop. And the other thing it shows is the durability, is how long these are sustained. And you can see there are some of those are the 10-year publications. So we're very confident that we can tell a patient who comes in with his hand on his head, we can make you better. We can do better for you than another round of epidural steroid injections. And we can tell them that if you're a candidate, an artificial disc will do better for you than a fusion. So the indications for the FDA were fairly basic, as Matt had said. It was 1 level or 2 level if they was running a 2-level study. And as Rudy and Terry said, it was initially for soft disc disease, which we expanded to hard disc disease and foraminal stenosis. They had to have failed a minimum of 6 weeks of care, and they had to have radiographic evidence. The contraindications were, unusual size, too small to support an implant, but basically these were consistent from study to study to study. This was not just exclusive to any one disc. So just to use ProDisc as an example, we were able to publish the 2-year data that the FDA had looked at when they gave approval, but we also followed all of those patients for 5 years. And we published the 5-year data with fairly good follow-up. It was hard in the US now. Patients are scattered, they're doing well, they don't want to come back for exams. But we again showed the durability between years 2 and 5. None of the patients were getting worse. They were all still very pleased. They still had segmental range of motion when we sent their x-rays down to medical metrics for digitized analysis. And the main thing we found at that time, and we're astounded to see it as early as 5 years, was that the reoperation rate was a fraction in the patients who had randomly gotten the artificial disc than those who randomly got fusion. We never expected to see that in just 5 years, but we started to see this was a 5x variability. We followed those same patient cohorts to finality with years 6 and 7 and actually brought them in. We did much better. We got an 82% follow-up rate at 7 years. Again, high satisfaction scores, improvements in VAS and NDI remained. The patients remained happy. Still, 1/4 as many of the patients in the artificial disc group who they were randomly assigned for ProDisc needed reoperation. So we were starting to see something very impressive for an advantage. So in 2019 was kind of the year of the meta-analysis. Enough of the initial data from all those studies I showed you had been in the public domain that people started to say, well, I can write a paper now because I can pull all this data and just do statistical meta-analysis on it. So here in 2019, this is a meta-analysis of 11 trials, 3,500 patients, pretty evenly divided. And arthroplasty had a significantly lower rate of symptomatic adjacent segment degeneration, overall reoperation rates at both index and adjacent levels. In 2020, there were 16 meta-analyses published. Again, people are jumping on the bandwagon here because this data is now publicly available, and you can write an impressive paper and get some good points. And all those studies, as Rick showed that the artificial disc patients were better, that there is no huge study, no large study that ever shows that they're doing worse than the patients who randomly got assigned to fusion. This was 8 clinical trials with 15 papers, 2,600 patients. Overall clinical success rates, and these are all statistically significant differences. And overall success rate, NDI success rate is better in the arthroplasty patients, neurologic outcome, satisfaction rate, and TDR, again, outcome difference of between 2 and 3 to 1 as far as reoperation rate. So we keep getting the same thing. The numbers are off a little bit, but they're always in the same trend. They're always showing significant reduction in secondary surgeries. This was in 2020. I think Rick showed this slide also. This was a meta-analysis squared. It's a meta-analysis of meta-analyses. Again, with the conclusion that compared to ACDF, the treatment of symptomatic cervical disc disease is superior in the patients who had artificial discs. This is getting more recent now. This is 2022. 7 studies with 600 patients, all randomized again. Statistically significantly better outcomes in NDI and SF36 scores, shorter hospital stay, and lower reoperation rate with a 3 to 1 difference. So in addition to pain reduction, that's what patients are interested in when they come in with their radiculopathy. Are we successful in giving motion to that segment? And does maintaining or improving segmental motion actually reduce the rate of reoperation and adjacent segment degeneration? Those were questions that we really wanted to know when we started these studies, but now we can harvest the data and find out. So here's a slide again showing multiple discs, for intermediate to longer term outcomes. And you can see at 7 years, where at the time this was published, there was data available for a variety of discs. All of them had accomplished that. They all had maintained the motion or improved it over the course of the years. It wasn't just one disc. This is from the MobiC 10-year study showing their superior level and inferior level ranges of motion in a 2-level study. and showing that they've maintained the motion. And the interesting subtext here is the average age of patients in the two-level study was in their late 40s. It was about 47 or 48. So at 10 years out, these patients now, the mean average age, the mean age is later 50s. They're 57, 58. And that still means that a lot of them are older than that. They're on the right side of the bell curve, and they're still moving. So this is remarkable because obviously if they had fusions, they'd have no motion there, and their overall motion would be decreasing as they continue to age. So we saw the same thing again with prestige with superior and inferior levels continuing to move. So we're not losing motion at the segments as patients age. We all had an idea in our mind qualitatively of what we'd like to see with motion, and this was just a simplified disc. And kind of interestingly, in the AP view, you can kind of see the coronal shift around the uncovertebral joints, and this is why both Terry and Rudy stressed how important the uncovertebral joints are and how you shouldn't do a complete uncovertebral resection because it's an important load-bearing participant in the process. In addition to the qualitative, we now have the quantitative. This was the paper that Dr. Pat Warden published just last month, where he was able to use a combination of in vitro cadaver data and the data from 1,700 patients with 7 IDE studies, and he's able to now put numbers and saying that physiologic motion is between 5 and 16 degrees, hypomobility is less than 4 degrees, hypermobility is more than 17. So as we're peeling the layers of the onion, we're starting to get better tools for future research. So now we can try to keep apples to apples to apples so we can really compare what discs are going to work out better for us in time because we have better metrics. But it took us time to understand that. So the questions again come, does motion contribute to less adjacent segment disease and degeneration, and will that lower the reoperation rates? To answer the question about adjacent segment degeneration, here's 10-year data from the Kellgren-Lawrence scoring by radiologists in the MOBI-C study between the superior and the inferior adjacent levels to fusions. And you can see that the patients who had ACDFs, the two-level fusion randomization, 73% of them, bless you, Scott, 10 years later, had adjacent segment worsening by Kellgren-Lawrence, but only 37% of the patients who randomized to 2 MOBI-Cs, that's 50% less. At the inferior adjacent levels, the same thing. It's like 2/3 of the patients, 66% who had two-level fusions by random design, now had adjacent level disease, but only 30% of the patients who randomly got their disc. So yes, motion does protect against adjacent segment degeneration measured by independent radiologists with a validated scale. Jeff Spivak and I looked at this in the ProDisc 7-year study, where we found that, and this was before we knew what Pat Warden's numbers were going to be, because this was 5 years ago, that if we did if we did a bad job, if very early in our learning curve we only were able to give a patient 0 to 3 degrees of motion, we didn't do any better for him really than an ACDF. 70-odd% of those patients had worsening at 7 years. But what we found is that as we got better, as the patients had better segmental motion, there was a linear decrease in the number of patients who had adjacent segment degeneration by using that same scale. So again, apples to apples, different discs, but showing that motion does lead to decreased adjacent segment degeneration radiographically. So it's not a question anymore. It is, it's data validated. There were multiple studies now this is a European meta-analysis, 20 studies, 3,600 patients. The key findings at 5 years, a significantly lower incidence of secondary surgeries in patients who had ADRs. Another article from 2022, again, high statistically significant improvements in adjacent segment degeneration radiographically, adjacent segment disease requiring any kind of treatment, including injections for amniotomies, and more specifically, here a 2-to-1 decrease in the need for a reoperation to change out the implant. So the same numbers keep coming up. As Rick mentioned, we're able to look at facet joint changes, particularly in the MOBI-C study where they had to get an MRI at 2 years, and they were able to show, as he demonstrated, that there's not a significant worsening of facet disease over time. This was short term, this was 24 months, but it gave us a good opportunity to look at that. One of the key endpoints is reoperation because it's binary. Either you had a reoperation or you didn't, so it's an easy one to define. And it's also one of the most important drivers of health economics. This is what payers look for because reoperations rates is what can cost them a lot of money, not a little physical therapy or even an occasional injection. So this was a meta-analysis specifically looking at secondary surgery after cervical arthroplasty versus fusion, and again showing index level 3.9 to 8.2, less than half. Adjacent level 3.2 to 6.9, less than half, and combination 6.5 to 13 degrees, exactly half. We keep coming up with the exact same information as we keep slicing that mountain of data in different ways. Revision rate, this was Dan Rue's group who looked at initial reop rates, index level reop rates of 3.9%. And so I can go back without hurting us here. But anyway, Dan's qualified where the reoperations were, and most of them were for radiculopathy, and that's what Frank Phillips found out also in his paper for the need for reoperation. But I think that comes from what Rudy was saying, stressed a very important fact that when you're decompressing the symptomatic side, you have to do a symmetric decompression on the asymptomatic side or less symptomatic side so that once you restore motion, you don't start a radiculopathy in what was previously asymptomatic. And I think that's what a lot of people didn't do and prompted those reoperations. If you do a good job right off the bat, you obviate the need to have to go back and do a contralateral decompression. So this was from the Prestige study, once again showing about a 50% reduction. So no matter how you look, where you look, again, we're comfortable that we're seeing it. But is the future all rosy? Well, we know it's not. It was really the Australian government who issued the hazard in 2020. It was Matthew's very courageous publication of the issues that he was seeing with his longer-term M6s. And that caused us at TBI to start to look at our M6 experience, where we had participated in their FDA study. We had contributed about 14 patients and realized that we had reoperated on 3 of those 14 patients. That's a very high percent. It agreed very much with what Dr. Scott Young had published. But we also were sitting on that big mountain of our own internal data. So we went back quickly and looked at our database and said, have we been doing the same thing to other discs and not realizing it? Well, we had done about 700 Mobi-C discs, and we only had reoperated on one that had a questionable diagnosis of osteolysis. We had operated on 624 patients and implanted Proteus, and we had operated on 0 of those patients. So, we were extraordinarily concerned, and we actually stopped, even though we were now as FDA approved, we stopped our M6 implantations at Texas Back. When we analyzed those cases, they were all more than 5 years out. Average was 6.8 years, just as Matt had suggested. There were no reoperations yet in the younger patients who hadn't aged out yet to that point. So again, we were concerned. This was one of our cases, the 2-week x-ray, the 2-year x-ray, all looked okay. This patient was asymptomatic at 5 years, started to have some complaints, not of horrible neck pain. His x-rays looked a little questionable, but nothing terrible. But we made him get a CT scan and saw this and said to this guy, you need to get a reoperation. He said, I'm not that bad. And, the question you have to ask yourself is, we didn't have more data points. So I don't know whether this was getting better, whether it was getting worse, whether it was stable. But would you be happy telling your brother, just watch it and see what happens when, this could be catastrophic? So we finally were able to convince this patient. But that's a problem, getting patients who are not super symptomatic to come back when we're structurally very concerned about what's potentially going on. And this paper, again, came from your country, showing, again, once more, a very high rate of osteolysis, 42%, and severe osteolysis with implant failure in a significant number of patients. So these are alarming things. Just to finish up on heterotopic ossification, it's generally not a big clinical problem. It's a radiographic finding. It's about 1% a year. They saw it in 13% of the prestige patients at 13 years. But these patients almost never need anything done. This is, again, as Rick Geyer said, sort of a soft, slow-to-develop fusion. It's a technical failure for us. It's a technical failure for the companies. This is not what any of us want. But if this is the worst that artificial disc replacement in the cervical spine throws at us, I think we can all tolerate this, and the patients are not unhappy. So in summary, extraordinarily strong evidence, no matter how and from where the statistical analysis has come from, in a variety of ways, all showing that cervical arthroplasty is a very viable alternative to fusion, if not a superior one, that the results are always similar or superior and really never inferior, other than in some isolated case series. But that doesn't hold a candle to the statistical strength of these level 1B studies, the randomized control trials, and the level 1A studies, the meta-analyses, that we can just layer one on top of the other, and I've done that. I apologize for that, but that's what they asked me to do. But what we're not seeing are disasters. It's so rare to see a case report of a failure other than failures that we know about related to materials, and the other failures that are reported are usually related to technique, and it's not to the implant. We do see increasing acceptance of cervical arthroplasty, although there are still skeptics, and it's a head scratcher. But it's just wonderful to be on this panel, and that was a unbelievable morning. So you guys want to do some more discussion, or you want to let everybody go get some coffee? It's up to the chairman here.